Dr. Bravata, I think you're on mute.
Try one more time. Oh, it looks like he's going to try to reconnect. I apologize. You know, this is what happens when you do live meetings like this. Your Wi-Fi connection can really have delays. So there he is.
All right, can you hear me now?
We can. Thank
Okay.
you.
Yeah, I had to restart. Okay, so now I've got audio. All right, everyone. So yes, my name is Dr. Kurt Bravata. So I'm a family physician, and I graduated from residency at Bronx Lebanon Hospital in New York in 2013, and came out to rural Bolivar, Missouri after graduating residency. My wife's family were living in Tulsa, Oklahoma, so we moved here to be closer to them. And so I actually work in Buffalo, Missouri, which is in Dallas County. And so it's a small rural town, and I live in Bolivar. And so I practice family medicine 4 days a week, and I also do rounds at the nursing home 1 day a week. And so when I came here in 2013, the goal was to be doing a family practice, subspecializing in geriatrics. And so that's where the nursing home practice came in. And the bulk of my patients are probably middle-aged to elderly patients, although I do some women's and children's. And so when I started around 2013, I started to have a number of patients, quite a few that were coming in, seeking opioid pain management. And, having been, from New York and practicing in the Bronx, I mean, I was familiar with patients, with drug-seeking behavior. I just didn't expect to have as much of it here as I was having there. And, in New York, it was very standard to place a substance recovery referral, or sometimes even more simply, you would just have the social worker come into the visit, and usually you had a social worker or a caseworker there in the office that could talk to the patients, and they could arrange to get them into a substance abuse program. So it was very easy to get them the care that they needed for whatever addictions they were struggling from. And so here, I went ahead to go place that substance recovery referral, and discovered that there was nowhere to send them. And that the closest addiction treatment center was about an hour away. And so being in Dallas County, it was about 45 minutes away to send patients to Springfield. And a lot of these patients that were suffering from opioid dependence were either Medicaid or uninsured patients. A lot of them did not have good transportation. Some, many of them were not even really motivated to seek substance recovery. So it's very difficult to get those kinds of patients into a recovery program that's about 45 minutes away, that you have no direct relationship with, that's with a different hospital system. So, I started talking to the other physicians, during our med staff meeting, and just said, well, what do we typically do with these kinds of patients? And they said, well, if a patient's causing you trouble in your practice, they can find another doctor. And I said, well, aren't we, isn't there like an avenue to treat their addictions? And they said, well, if a patient's causing drug-seeking behavior, maybe we'll refer them to like a pain management doctor, or, I mean, we can place a substance recovery referral, but it's, they're most likely not going to go, and they're probably just going to hop on to another doctor. And, so at that time I said, well, I wish there was something that we could do. And, I didn't have, I didn't have my Data 2000, X waiver for Suboxone at that time. And I really wasn't familiar with treating addiction myself. Although I did have some behavioral health interests, of course, in family medicine, we learn a lot of behavioral health, and, we learn the SBIRT, for, screening and referral to treatment. We learn motivational interviewing and, how to do some levels of counseling, and positive reinforcement during our visits. So, I had some training in that. And at one point, I kind of thought I was interested in going into psychiatry. And so, I wasn't scared of patients with behavioral issues. And but I really wasn't sure, how to go about treating those patients. And luckily, I had a pharmaceutical rep at that time that came in and talked about a medication that's the a depot form of naltrexone. And if you look it up, there's a brand name for that medication. So naltrexone, kind of like naloxone, which is in Narcan, blocks mu opioid receptors. And mu opioid receptors are what opioids act on. So one of the benefits of naltrexone is that it's even in its oral form, it's longer acting than Narcan, and also is effective in treating alcohol abuse. And so with the way it works for opioids is direct antagonism against the mu opioid receptors. But for alcohol, because your body releases endogenous opioids called beta endorphins, when you have a high, like when you drink alcohol, those endogenous opioids also act on mu receptors. And so if you take naltrexone, it blocks those receptors. And so especially for patients who have combination alcohol and opioid abuse, using naltrexone is a really good option for them. The issue with the oral naltrexone is a compliance issue, and that is that patients have to make a decision every day to take that, and they get no positive reinforcement from taking naltrexone because it's not an opioid and it has really no psychoactive effects. It really has minimal side effects altogether. Some patients will complain of maybe a headache or nausea, and maybe some insomnia. And then, of course, there's always the risk of opioid or alcohol withdrawal if you give it to someone who has been drinking or using opioids in the last 7 days. The benefit of the injectable form is that it lasts 30 days. Actually, it lasts probably closer to about 32 days, but the highest level of effect is within the first 28 days. And so every 28 days, you give them an injection, and that blocks those opioid receptors. And so it really satiates their cravings for opioids and alcohol, and enables them to be substance free during that time period. If they do decide to drink or use opioids, they won't get a high and they won't get positive reinforcement. And so using that medication, I was able to start seeing patients in my family practice without having any additional certification for treating addiction. Now, I went ahead and I sought my own, training. I went to various, addiction classes, and went to peer substance abuse support training, and various kind of behavioral health trainings, and got connected with various groups within the community, like NA, AA, and started collaborating with social workers within our hospital system, so that all of these patients who I was seeing for addiction in my practice also had a social work consult. And the way I initially set it up was that patients that were interested in seeking addiction treatment, if they weren't already my patient, I would have them see the social worker first, and then that would allow me to kind of get all the history I needed and to feel like they were kind of plugged in and knew that they were going to be getting counseling. I don't require that now because I think it's a barrier to treatment to require that they see the social worker first. And a lot of kind of the direction that addiction treatment is going in this country is it's moving further away from kind of the psychiatric behavioral health model and more into the medication first model. And the reason for that is because of the fact that there is this kind of physiological, biological component to addiction, where if you can use medication to treat the cravings and to block the substances that they're using, you can stop the cycle, and then that allows them to engage in behavioral therapy and counseling and all those things that they need to do to make behavioral changes, but you can actually stop the cycle right away with medication. So I do require my patients, well, I strongly advise my patients to be involved in counseling, but I don't require that as, for access to treatment. And so when I started treating my patients in my practice, I probably was seeing about 5 a month. And I started carving out time at the end of my day twice a week, where I had about 3 hours twice a week. And one of the reasons that you need a little bit of extra time to be able to treat these patients is if you're going to start them on medications for addiction, you have to do an induction. If you're going to be using naltrexone or Suboxone, or buprenorphine, which is generic for Suboxone, and comes in various brand names, is that you need to do a challenge dose. And so a patient comes in the office and you give them that challenge dose. And so then you have to monitor them, and you're supposed to monitor them, for about an hour to 90 minutes, before giving them a higher dose. And if you're going to give them an injection, that's going to last 30 days, you definitely want to make sure this medication is not going to cause any major problems. And so you counsel those patients about injection site reactions, and you talk to them about the risk you could get. You can get an infection anytime you have an injection. You could be allergic to the medication and all that. So anyway, so I started providing treatment in my practice for patients, seeing about 5 a month, and then eventually I was seeing 10 a month, and then I was seeing about 15 a month. And over a period of a couple of years, I started realizing, wow, I'm the only one in this entire hospital system that's doing addiction treatment. There have to be a lot of other patients that need this. And, just within my own practice, I'm starting to have such a increase of patients that need addiction treatment. We really need an addiction treatment program for our hospital. And so I petitioned administration, and they were kind of like, well, talk to psychiatry. I talked to psychiatry, and psychiatry was like, well, we've kind of gone down that road before. We're not really interested in addiction treatment. And, we'll do counseling, but we really don't want to be involved in an addiction treatment program. And, so anyway, so I said, well, I guess I'm going to be the one to do this. And so I went ahead and got my my DATA 2000 treatment waiver for prescribing buprenorphine for opioid abuse. And I was a little nervous about doing that because, it's a controlled substance, and, I really I wasn't familiar with how to use that for treating opioid dependence. I had some knowledge about it, but I'd never done it myself. And, but I started thinking, I do pain management in my practice. I do drug screens. I do narcotic contracts. I'm not afraid of prescribing opioids for pain. Why should I be afraid of prescribing opioids for addiction? And I had discovered that in treating patients for opioid dependence using Vivitrol, if they were very high, opioid users, that were like heroin abusers or abusing fentanyl, Vivitrol was just not going to work for them. And many of these patients couldn't get, they'd be actively using. And so in order to give them Vivitrol, they had to be 7 days sober. So I couldn't even get them on Vivitrol, because if you give naltrexone while they're using, they're going to go into severe withdrawal. They call that precipitated withdrawal. And so, and then the risk with Suboxone, or the generic form buprenorphine, is that you also can precipitate withdrawal. But that's why they're supposed to be about 12 to 24 hours since their last use. Some doctors feel comfortable giving it after, if they've used within the last 6 hours, and you just give them, like a 2 milligram challenge dose and just watch them in the office and see how they do. And we've done that for patients that feel like they, they're like, well, if I don't get that medication now, I'm going to use, so anyway, so I did get the training, and, we started kind of small, prescribing for a few patients in my practice. And then finally, we got administration at our hospital to agree to setting up an addiction program. And so we got a site, and currently we're actually located in the Stevens Pharmacy building in Bolivar, which is actually owned by Representative Mike Stevens, Missouri State Representative, and he's also a pharmacist. He's retired now, but his pharmacy collaborated with us to be able to, get the medications that we needed for the treatment, but also for the induction doses. So it was so great that we were actually located in a pharmacy building, because you could just send the patient to the pharmacy to get their induction dose, even if they were a walk-in that day. So they could go upstairs, they get the medication, they come down, and then we could monitor them in the office and give them the induction dose. And so when we opened that practice, I opened it with a nurse practitioner, who, by the way, she was a family nurse practitioner who had training and experience in pain management. She actually came to me directly from our pain management clinic. That experience really made her a really good candidate for addiction treatment, because she kind of knew all the protocols of all the drug screening and monitoring and, contracts and all that. And so, and also she, knows how to do injections and all that. So anyway, so we started with a rooming nurse, a nurse practitioner, and a front desk girl. And then we also had access to the behavioral health counselors, within our hospital. In fact, in that office that I'm located, we have counselors. And so we started with about 15 patients a month, and now we're seeing about 200 patients a month after about, I think we're almost 3 years now. And so that practice has just really exploded. And especially through COVID, we've seen a lot of patients, new substance abusers, or patients who were, kind of occasional alcohol users, now drinking regularly. We've seen a lot of relapses. One of the benefits of the pandemic is that we've had increased availability, for telehealth, and that the policies have changed to where, it's pretty much open access for telehealth. And also in addiction and behavioral health, you can actually do phone visits. So those don't even require a visual component. You can actually just call the patient and do a visit that way. And so that's really enabled increased access for our patients. And so now we're actually doing more inductions. And we do few inductions on via telehealth, but we have done more than what we had before. And we definitely do a lot more follow-up visits via telehealth. We've also increased our access to satellite clinics. So we actually have 3 satellite clinics, which are associated with our hospital system. And 2 of them, I think, are federally qualified health clinics that are like subcontracted with our hospital. And so my nurse practitioner actually travels to those 3 locations. And so that has increased access to the surrounding communities that our hospital serves, without those patients having to necessarily come directly in. And then they can also do follow-ups via telehealth if needed. So we treat opioid dependence, we treat stimulant use disorder, we treat alcohol use disorder. We've had patients which we've treated for gambling. And you can actually use Vivitrol or oral naltrexone for gambling. You can use Luvox, which is an antidepressant, kind of antipsychotic medication, which also helps with gambling. For those patients who have alcohol, who are active alcohol users, like I said, you can't immediately put them on Vivitrol. So we use a medication called acamprosate. Another name for it is Camprol, which is similar to gabapentin. That medication helps reduce their cravings, but also it kind of helps stabilize them so that they don't, it kind of helps to prevent withdrawal and reduce their risk of seizures. We also use benzos like Ativan or Librium to help with symptoms of withdrawal. And we just prescribe those very judiciously so that, since those are controlled substances and benzos interact with alcohol, we tell those patients, don't take those while you're actively drinking, but as soon as you stop, if you start to have, tremors, anxiety, symptoms of withdrawal, that you can use that. For patients who are withdrawing from opioids, clonidine is a medication that's commonly used, and that medication is, as you may know, is a medication that's used for blood pressure, and it actually helps treat the sympathetic symptoms of opioid withdrawal. And so if you have a patient take about 0.1 milligrams of clonidine 2 to 3 times a day, that helps treat their symptoms. And then you treat the other symptoms of withdrawal, such as muscle spasms with muscle relaxers, nausea with antiemetics, pain with NSAIDs. We make sure that these patients are following up with their primary care doctors. If they don't have primary care, we get them established. We do hepatitis C, HIV, and hepatitis B testing. We've actually started treating hepatitis C in our practice. We only have a few patients that we're doing that with. If they can get to the infectious disease specialist and they're willing to see the infectious disease, we usually refer. But if there are patients that we just feel are they're not gonna seek treatment, we make sure that we treat in the practice. I think I'll probably stop there. If you guys have any questions, I want to leave some time for questions.
So you can either submit your questions via the chat component of Zoom, or you can just unmute yourself and ask your question. Since we're a small group, that would probably be your best route. Any questions? Well, Dr. Bravata, we really appreciate your time that you took today. I do want to point out that the October through December issue of the Missouri Family Physician is going to focus on addictions medicine.
Oh,
so if Bill hasn't reached out to you yet, I'm sure he will. But I also want to encourage our students. We are always looking for articles where you collaborate with one of your faculty members, and maybe there's a topic or something that you want to include in the magazine. And you can reach out to Bill Plank in our office. His email, just now give you a second to get a pen and paper if you want to write it down, is bplank@mo-afp.org. And it's also on our website and you can find it there. But we would love to have an article that you collaborate with another family physician or another physician on addictions medicine for that issue. So Bill, if you want to throw anything else out, you can, but I know we're running up on our 30 minutes and I really want to try to keep us to that time frame. So.
Yep, Kathy, thank you for that. The only thing that I would add is in the past, we received great compliments from our members whenever students submit articles and residents submit articles when anybody does, because our physicians love to see the next wave of physicians getting interested in and some more of the education pieces and more of the research. So I'm sure if there's something on your mind and you wanted to bounce it off Dr. Bravata or like a faculty member or teacher that you have, I'm confident that they would love to have that conversation with you.
Yes, and you guys can definitely put students in touch with me if they have any questions, or want to follow up with me in the future. And one thing I forgot to mention is, that currently there is an open practice pathway to become certified in addiction medicine, to become board certified in addiction medicine. And that's through the American Board of Preventative Medicine. They're the certifying body for the addiction medicine boards. And that pathway is open until 2025. So that, you still can practice your family medicine and be subspecialized in addiction medicine if that's something you want to do on the side. So it's exciting. I did get certified, and I felt it was important for for me to do that because of the fact that I was running an addiction clinic. I think if you're just providing addiction medicine practice within the family practice setting, I don't think you need the board certification, although the training is really helpful.
Thank you. And I put Dr. Bravada's email address in the chat. So if any of you are interested in reaching out to him afterwards, I'm sure he would love to hear from you. So any questions after all of this? Well, thank you so much, Dr. Bravada. We appreciate your time, and we appreciate all the students who joined us today. And our next session is in May, and it's going to be on public health. So Dr. Kanika Turner in St. Louis will be presenting that session. And I'm going to look up the date real quick, which is May 26th at noon. So we will see you all then. Thank you very much.
Well, thank you all, and best of luck to all the students. Bye.
Thank you.